Hey team, before we dive into today's episode, I've got a quick favour to ask. The Women's Football Hub merch store is now live, and every purchase helps support our work as a non-profit championing women and girls football from the ground up. There's something for everybody, adults and kids. There's loads of colours and sizes, and your support helps us grow the game one piece of apparel at a time. Just head over to www.womensfootballhub.com to check it out. Thanks for backing the hub, and now let's get into the episode. Hello and welcome to Women's Football Hub. I am your host for this episode. I am Carolyn Kent, and today we're going to be discussing long-standing groin pain. Now, who better to get along than somebody who has actually got an MSc in sports medicine from UCLan, also a physiotherapist, which is great because we're discussing rehabilitation, but currently doing his PhD in long-standing groin pain and also looking at exercise and rehabilitation. Welcome to Women's Football Hub, Christos Pippas.
Hi, Carolyn. Thanks for having me.
You're very welcome. Thank you very much for giving us some of your time today. Now, of course, you have decided to specialise in long-standing groin pain. It's the one area that I find that when people come into football, the groin is probably the one. They're usually not bad with ankles. They're all right with knees, and then it gets to the groin, and there's like, hang on a second, there's so many things in this area that it could be. What made you want to kind of study and look at groins?
Yeah, you're absolutely right. One of the most common injuries in football, in sports in general, but in football especially. I'm not really sure what made me get into this. I just was interested in this, and after my MSc, was trying to figure out what to do next. And things came along, and I found a way and the people to connect. And then I got to my PhD about groin pain.
And was there any kind of particular areas of groin pain? Because obviously the Doha Agreement came out, didn't it? And it made us define some terms. So was there certain areas of groin pain? Was it adductor-related groin pain you like to work at or look at, or was it just lots of different things?
So the Doha Agreement, as you mentioned, is basically a consensus back in 2015. Then we have the ESCA meeting in 2024, which is actually an improvement of the Doha Agreement. So the basic stuff are the same between those two consensus. So we have four main categories in groin pain. We have the adductor-related groin pain, where the injured area is around the adductor muscles. We also have the iliopsoas-related groin pain. So the pain is in on or around the iliopsoas muscle. There is the pubic-related groin pain in the pubic bone or adjacent areas, and the inguinal-related groin pain. So we have the inguinal canal and the area around it, but we do not have any palpable hernias there. So when we talk about inguinal-related groin pain, we're talking about irritation in the inguinal canal.
Yeah. And of course, those are areas that are very close together, right? And one of the things I tend to find when I get students through is they struggle to almost diagnose, well, which one of those things is it? Do you have, if we think about assessment for that sort of area, what would be your type of go-tos with that? So let's start with adductor-related groin pain, for example.
Yeah, so actually for every entity, we have basic clinical examination comprised of palpation, resistance testing, and stretching. So these are the main clinical tools we have to examine. So based on that, if you have tenderness on adductors and you have also positive resistance testing, so you're going towards adductor-related groin pain as a diagnosis. Then the same goes for iliopsoas. So you have pain on the iliopsoas. You also have some pain during resistance testing, maybe on some stretching of that area. So maybe your diagnosis is closer to iliopsoas-related groin pain. And the same goes for inguinal-related groin pain, but you have a bit of different structure there because you don't have actual muscles on the area. So you have the same clinical examination, but you might also have some abdominal adductor-related pain. So when you stress the abdominal muscles, you might have some pain categorized as inguinal-related pain.
And I think if you were to speak to any football physiotherapist, the first thing they would say is, yeah, I see lots of groin strains. From your perspective, do you feel that we're getting to a point where that sort of adductor-related groin pain is well managed in football?
In my opinion, not even close. So
Yeah.
this is something really strange in that area because we know we have a high rate of groin injuries, around 20% in men's football, but we are just trying to get on top of that research-wise because especially in women's football, we have a really poor research on that. In men's football, we have more research. We're trying to figure out many things. We know that in football, we basically see some specific injuries in the groin area. However, we're trying to make prevention better. We're trying to make rehab better, to figure out some basic stuff around that. So there are many things we could say about these things, but in general, we're trying to improve things in football.
Yeah, and I think it's fairly safe to say, like, I mean, from my experience, when we're dealing with groin related pain and you're not quite sure what it is yet, you're more likely to see hernias in male footballers than females. I think that's pretty well established. Do you have some tips for anybody for deciding it's a hernia or no, it's not a hernia? Do you have anything there?
Yeah, it's basically a part of good clinical examination. So if you want to move forward with the basics, you have to get through this. You have to maybe have a doctor or a physio for examination. We have to know that there are other causes for groin pain apart from the basic entities. So the examiner has to do the clinical examination properly, maybe, tell you you have to visit a doctor, you have to look at this because maybe there is a suspicion of something else in the area. Maybe there is a palpable hernia, maybe not, but that doesn't mean that it is not there. So, as we said before, we have to do the basics like palpation, resistance testing, good history, and here comes the ESCA consensus with the imaging.
Hmm. Now that's an interesting one because I remember when they were kind of looking at all of that, they scanned lots of groins that had no pain and they actually found things on those scans and they're thinking, well, actually, therefore, how useful are these scans to us?
Yes, yeah. There are some studies, so they tried to combine clinical examination and imaging and correlate those things. There is some correlation in some entities, poorer correlation for some other entities. Clinically, we use that. I worked in football, so I have a general idea of how things goes here in Greece. We combine imaging, but I base my clinical examination and my opinion on clinical examination rather than imaging in itself.
Yeah, and it's interesting, isn't it, in football, sometimes even if your clinical examination, you're like, yeah, I know exactly what it is. It's getting a scan anyway, isn't it?
Yeah.
Sometimes we scan not to miss things. Like it is funny because I have often had that kind of reflect to myself that in another environment I wouldn't be asking for that scan. So it's
Yeah.
sport is a very different world at times. So let's kind of move on towards your PhD. Can you share some of your key findings, but just the things that you're looking at? Because I know you're not obviously finished it yet.
Yeah, it's a huge area to research. We just started with some basic exercise searching, like which exercise can help to improve things. At first, at healthy subjects, football players. So we tried to see about the Copenhagen Adduction Exercise, which is an exercise widely used in sports, really easy to do on pitch, and you don't have to have any equipment for it at all. You just have some time to do the exercise. So I also know a group from Spain working on that, and they are trying to see what's going on with the Copenhagen. So we know so far that this exercise can increase eccentric strength of the hip adductors,
Yeah.
but although there is some research on prevention, we cannot draw definite conclusions from that because of low sample size, small sample sizes, small effect sizes. So we cannot say that we have the key components to prevent groin injuries. So I know that there is more research on that currently. But apart from that, now the general idea is to build a rehabilitation protocol. So we know there are many rehabilitation protocols so far. One strong one is from 25 years ago, or from Per Holmich. So there are many improvements that can be done. There have been some protocols that improved things like a return to sport criteria or progression criteria, changing the exercises. But there's always a question, which is better, why to use that exercise and not the other exercise, what's in the literature in general about that. So we're trying to bridge the gap between research and clinical practice.
Yeah.
That's the main thing.
I think that's a key thing, isn't it? Because there's a lot of research articles out there that say a lot of things, but actually you try and bring them into clinical practice, especially in a sporting environment, and you're like, we don't have time, we can't actually fit that in. Now, talk to me about the Copenhagen, because obviously the Copenhagen adductor exercise, it's not an easy exercise to do if you've never done it before. I mean, like, do you, because I've got a lot of players who are probably undertrained that I work with. So I wouldn't start them on the long lever Copenhagen. If you were starting with not so much a professional player, but somebody that had some recurrent groin pain, really looking to try and prevent this injury recurring, where would you start with somebody who maybe wasn't quite at that professional level?
Yeah, that's a great comment because that's exactly what we have to do in practice. So in research you can make things as you want, but if you have a player with high levels of pain,
Yeah.
you have to find something that keep the pain low, but at the same time you build that tissue adaptation along the way. So there are many options, and although there is some research, clinicians can also have their own opinions on how to approach the matter. So you can start with isometrics, which is something we also integrate in the protocol we're building now. Maybe you can start with a squeeze exercise. So that's a simple thing you can do. Use a soccer ball and just put it between your knees. Just start squeezing. You have to pay attention on the pain. You don't have to push really hard because we don't need more damage on the tissue. But you have to have to be on the safe line and just push as hard as you can, but without any pain. That's a quick start you can do before you start the Copenhagen.
And let me ask you this, how do you explain that to players? Because obviously one of the things I've found, because I'm a big fan of isometrics actually, and that is where I'll typically start them, short lever and long lever. I'll start them there,
Yeah.
right? With a football or with a medicine ball, whatever they've got access to. But it's interesting seeing the players go from, well, why am I, there's attitudes with players, for example, well, if it hurts, it must be doing good. Right? There's
Yeah.
there's there's some players that you come across. If it's not hurting, it's not doing anything. So that's a potential barrier that you come across. How do you explain it to players with regard? Because I often explain it about we're trying to build some capacity in the tissue. We're trying, you've had this injury or you've had a long-standing injury. We really need to, and I also talk to them about just settling the brain and just letting it get used to pain-free movement again. And how do you explain that to your players though? Because I tend to find that athletes, if it's easy for them, they don't want to do it. Does that make sense?
Yeah, sometimes I find that players have an image on their minds that with them on the pitch playing, like they have to do it quick. So sometimes you have to explain that there is a process before you reach that level. And some players, it depends on the character of the player. Some players can listen to you and listen to all the process you explain to them. Other players are not interested that much in, explaining tissue things and how it goes and what can you do to load the tissue. So there are different approaches, but the main thing is that you have to explain in some level so that they understand that this is not in one way and one direction process. You have to combine things. Maybe that's a part of the clinical aspect.
Yeah.
So you have to think clinically and see, I have a human being in front of me, so I have to find a way not to implement my ideas, but maybe present 2 or 3 different exercises to them so they can choose one of these exercises, but these exercises have to have a certain characteristics.
I like that patient choice on exercise. I love that.
Yeah.
I'm a big fan of that because actually, in my youth, way back in football, I would give them like lots of exercises, and then they would pick the easy ones.
Yeah.
That's what they did. Or you'd have the other subset who would pick only the hard ones to do, and they'd come back in and say that things were uncomfortable. But that was back when I could not program to save my life. So you've taken them from isometrics, they're lying down, they're maybe doing some isometric squeezes with some holds. You've then got to a point where you want to move them on. What type of thing would you move them on to after that, especially if you were dealing with adductor-related groin pain?
For that, the main thing is to start loading, but not only, exercise wise, but also functionally. So maybe that's a combination of functional and strengthening exercises. In general, I think we have to build not only in one direction. There are many parts of the rehabilitation process. So what's the point of just strengthening the tissue and not letting the tissue adapting to functional movements? I'm not saying you just start directional changes, but just try to put the muscle under conditions like a slow running, but always the pain is your limit. So you have to have a pain level which the player shouldn't cross and stay within that range of pain. And you could do anything within that range, actually.
And I like what you said there because I think it's the multi-planar movements of football, isn't it? And I often look at, and sometimes I'll break it down for the students and I'll say, look, what is it that these players do? And start at the end and then work those movements backwards to where you are. Like sometimes just that backwards chaining of rehabilitation. I think that's one thing I have definitely also noticed is sometimes I have had players come through who've maybe been seen somewhere else and they are doing primarily frontal plane sort of
Yeah.
motion, and they and they're loading heavy and they're saying, I've got strong legs. And I'm like, yeah, you've
Yeah.
got strong legs in one direction. And then you might take them onto something like a Copenhagen and they're like, I can't do that. I'm like, okay, can we start there then and just have a little look, And do you ever get that? Do you ever get that sort of conflict where somebody's been working with someone else and they come in with attitudes and beliefs and you go, yeah, we're going to totally change what you've been doing just to see.
Yeah, I think that happens all the time. It depends maybe on the bigger organization and the mentality behind it. But in general, I think you have to deal with people. So you have to find ways to, maybe give 2 or 3 options. So to make it easier for them, at the end, you have to have some specific parameters during the rehabilitation. So, you have to load the tissue, you have to reduce the pain they have, you have to do all the movements they are doing during the training or games. So these are some basic stuff you should do during rehab.
And you've obviously been speaking about, you need to keep the pain, either zero at the beginning or within a certain range. What's your range? Because different people have got different ranges when I speak to them.
Yeah, that's true. I don't know where different opinions come from, but I am not very, but quite aggressive. Like maybe keep pain at 2 or 3 out of 10
Yeah.
from the beginning. So if you just look how the tissues react, if the player tells you that, you know, tomorrow I have more pain than usual,
Mhm.
so maybe something we did wrong yesterday, we loaded the tissue more, so you have to reduce some intensity. But with experience, you can avoid these things, and you can keep some safe ranges regarding pain.
Yeah, and listen, there always is the chance for a relapse, isn't there? Are there any sort of
Yeah.
common mistakes though that athletes or maybe clinicians make during that sort of rehab process that you're like, do you know what? If I could change one thing, it would be this.
The main thing is that I find that we think very complicated. Like we are trying to complicate things and we don't stick to the basics. So this is really important for me. And maybe, if not all, most mistakes come from this. So you have to have some basic principles in mind, and then just enjoy the process. Like, why not give the players some options, like we said about exercises? So you have to have some principles. My exercise, I need to load the tissue. I need to know that this exercise will bring some strength. I need to know that this exercise will also allow some functionality. So these are some basic stuff you have to stick to, and then you have to figure out which exercises are ideal to the player. So you just have 3 or 4 options. So you tell them we have that equipment, and you can choose. Now choose your exercise, and we can move forward with that. If later on you don't like this, we can change, and we pick another exercise.
And that's the thing, isn't it? I think when you're dealing, especially with that higher level of athlete, there is player choice. Like,
Yeah.
there
Mhm.
is definitely player choice. This is not a dictatorship when I'm in the gym. Players will often say, I want to get back to running. When can I run? Because that's a big thing that they want to do. At what point do you say, well, these are the things that I need for you to be able to run. These are the things that I need for you to be able to cut and change direction? What is it that you look for in particular?
Yeah, that's another like debates in the growing area. I know there's in other areas as well, but looking back to the research done so far, there is no specific criteria for return to running.
It's interesting, isn't it? For something that's so common,
Yeah.
there's no, these are the parameters that we need to, I mean, because ACL is probably the gold standard where it's got everything like almost, here's your parameters, here's what you're looking for.
Mm.
But it is interesting that there isn't a return to running protocol with something that's as common as groin pain, right? Are there things that you look for though, just from a personal choice perspective? Do you kind of go, if they can do this, they might be able to do that?
Yeah, for me, it's a combination again. So you have to be able to do some clinical examination without pain or at the levels you need the athlete to be,
Hmm.
but you cannot forget functional. So I focus on that, and you have to have that combination. So you move forward like safely, and you're sure that the next step can follow, but you have also completed the previous step, like slow running or something like that. You have to have the ability, the tissue has to have the ability to cope with this loading.
Yeah, it's interesting. And do you look sort of above the groin as well? Do you have a little look abdominally about what's going on, or do you kind of focus in just on the adductors?
Rehabilitation wise, you have to strengthen all the area. So you basically see when you have an athlete with groin pain, you probably have pain in the lower abdomen as well, maybe iliopsoas area. So you have to load all these areas as well.
Yeah, you make a really good point there because I think when I think back to some of the early sort of groin pains and what used to really throw me off is they were sore in multiple areas. And what I used to find was is that as things started to get better, the pain would normally localize to that
Yeah.
one area, and that's I'm like, ah, that's what it was. And even although yes, your clinical exam is very important, but I think when somebody's just starting out, I think groins can be relatively intimidating. It's close to an intimate area of the player's body, and then of course there's lots of things in that one area anatomically that potentially it
Mm.
could be, and that's really where it comes down to your subjective, your patient history, and your good clinical exam, right?
Yeah, that's the thing. Now you reminded me of a study Andreas Serner did with a digital mapping.
Mm.
So you have the body map and all the four entities of groin pain interlapping, like you might have adductor-related groin pain in the adductor area, but you also might have a pubic pain going into the adductor pain area, let's say. So you're not sure which really is. So you have your clinical examination, the player refers some pain on adductor squeeze maybe, but this might be provocative for pubic related pain also. So you might have two or three entities at the same time which provoke pain. So you have to deal with everything, and the best way is to address with exercise.
Yeah,
Probably.
it's interesting, isn't it? And we talk about exercise. Do you have staples or go-tos that you're like, yeah, I like that one? What do you have? Do you have ones? And obviously, you need to think about function. It needs to be clinically applicable to the player. I get that. But I've got favorites. Do you have ones in particular with footballers that you go to?
I use the Copenhagen very much. I'm trying to now change the way I think because I used to give some specific exercises like we were discussing before. Now I'm trying to be more open, like to see what they like. Maybe I could use some isometric. I didn't do that before, but now I see that you have to do that if the pain level is high. So I think in general, we have to do some changes in the way we also think if we need the whole area to change the way they think.
Yeah, as I say, it was one of those areas that I kind of like the shoulder that initially terrified me. I was like, oh my God, there's so many things in here that it could be. But then actually, I now actually really like them because I'm like, they're when you work it out, it actually feels makes me feel clever, and I like things that make me feel slightly clever at
Yeah.
times. But when we talk about groin pain, what's the future look like? Christos, is there technology coming in here? Is AI going to help us in any way? Is there anything coming in the future?
Yeah, maybe technology always has some place for sure. I'm not really sure what will happen regarding this, but I know that we have many things to learn
Mm.
in groin pain and rehabilitation prevention in general, and in women's football as well.
Hmm.
So there's so little on women's football so far in groin pain. So technology or no technology, we'll have to go deeper on that because we're just learning now what to do and how to approach things. I know there are not much to on rehabilitation for women's football. I know there are not much for prevention.
Yeah, I mean, I tell you what, there's so much, and also when you add in the fact that you can also have pregnancy in there, and then that pelvic girdle pain, and so there's so many things with regards to women's football that I think there'll be PhDs for years
Yeah.
coming on in that area. It's interesting because it's difficult to take the groin pain from the male research and then just bring it across to females. And I'm very careful with the anatomical stuff because obviously in ACL land we're now sitting saying, well, actually, how much does the anatomical stuff actually matter? And then you've got another camp saying, well, of course it matters. So I'm very careful that I don't annoy anybody when I talk about these things. But certainly from treating both male and female players, they do both get adductor-related groin pain. They may not be exactly the same, but they both get adductor-related groin pain. And I think my big thing at the moment is current evidence shows us that if you load female athletes, they should respond similarly to male athletes. And it's the question is the big danger with female athletes is underloading them. because you will make it a bit easier for you. That's the big thing, is pushing them a little bit more. But would you have any advice that you would give to maybe younger physiotherapists, coaches that are working with athletes who are prone to groin injuries? Would you have any kind of advice for them?
Yeah, I would say you just go with the basics. There is the basic science. So
Mhm.
far, we know some basic stuff uh, regarding anatomy, regarding tissue loading, regarding rehabilitation. Maybe we know less about prevention, but we have to think clinically. You cannot say to the club or the players, you know, we will stop doing things for prevention because, research doesn't give us anything.
Mhm.
So you have to do something, but you have to stick with the basics and then you have to think clinically, in my opinion. You cannot stay on one side, on the other side. You have to like bridge the gap between this clinical practice and the research. This is the best advice I could give.
Yeah, and I think, I've heard that so many times. I've heard clinicians saying, students are coming out of university and yes, they know about evidence, but they're not able to apply it sometimes. Where can any listeners learn more about your work or potentially get in touch with you?
So I'm currently doing my PhD in the University of West Attica in Greece, in Athens. So they can find me on Twitter, maybe on LinkedIn, Christos Pippas. It's easy to contact me now. It's an easy name to find.
Yes, yeah.
So happy to reply to anybody who would like some chat around growing pain.
Yeah. Christos, it's been absolutely lovely to talk to you today. Thank you very much for giving me some of your time and good luck with the rest of that PhD because I know how much of a mountain that is to climb. If you have been working with groin pain, either in the male or female game, please always follow the evidence and we will speak to you soon.
Thank you for listening to Women's Football Hub. The information within this podcast is for informational purposes only. No material on this podcast is intended to be a substitute for medical advice, diagnosis, or treatment. Please contact your doctor or another healthcare professional if you have any questions about anything raised in this podcast.